In the last couple of years, we have incorporated the frailty scale, the one that is recommended by the International Myeloma Group, which was published a couple of years ago by Palumbo and colleagues. And I think it's a very useful tool because in patients not candidates to bone marrow transplantation, I mean elderly patients, it's generally a population that is not included in clinical trials. So a lot of toxicity are found when we treat this patient, mostly with triplets. So it's a very useful tool, and we have recommended. I'm part of the Grupo Argentino de Myeloma Múltiple, the Argentinian myeloma multiple group, and we recommend it. It's easy. It's available on the web, so we use it and helps to decide which treatment to use. Frail patients use generally doublets or less intense treatments. Otherwise, not frail patients or what we call the go-go patients, we use full dose and treat them. That's a very interesting question because studies that shows real-world evidence sometimes does not reflect what randomized controlled trials conclude. So there is a gap in the outcomes, not only responses, but survivors as well in terms of these different studies. So for us, it's very important the result from real-world evidence studies. In fact, one of our limitations in Latin America is that unfortunately we do not have any published data, local published data in the international literature. So we are starting to work on national and Latin American registries in order to understand our reality. So real-world evidence is an important tool. It is well known that around half or more of the patients in the clinical practice, in the common clinical practice, should fail selection in randomized controlled trial, and that's very important to have data on that. So yes, we value the publish of real-world evidence. Another very good question. Our conduct have changed due to the COVID-19 pandemic. I mean, the COVID pandemic arrived in our country on mid-March, and since that time, the Argentinian group of myeloma had recommended not to treat any biochemical relapse. So right now, we are not treating any biochemical relapse. But well, as the pandemic has become timely larger, I mean, I think we are going to recommend what we recommended before the pandemic which was to treat patients in biochemical relapse if they had a very aggressive disease diagnosis, or, for example, if they have what is called the evolving pattern of the monoclonal protein, or if the patient has high-risk cytogenetics. But let me mention one important thing, that in our country, only one center perform cell sorting in multiple myeloma. So we have difficulties in patients with perform FISH analysis, and we don't know if they're really negative. So a large amount of false negative we have in our country. In my center, which is a university hospital that works with mostly private insurances, we are kind of fortunate, because we almost have access to the novel medications. I mean, access to the IMiDs, lenalidomide, pomalidomide, to proteasome inhibitors such as bortezomib, ixazomib, and carfilzomib as well. and more recently to monoclonal antibodies, daratumumab and elotuzumab. We can have nearly all the treatment options that, for example, our colleagues in Spain has. So for me, there is not a limitation or a barrier to treat my patients. But I must say that in the public health system, sometimes the access to these novel agents, which are most frequently very expensive, is limited. Yes, I can tell you two papers that call my attention. For example, one of them it's a real world evidence that Lelu and colleagues are going to present from Europe, and it's about the use of carfilzomib combinations in patients exposed and refractory and or refractory to lenalidomide. And there is, they found that in about more than 500 patients that the real world evidence shows lower PFS than randomized controlled trials. It shows lower responses as well. And they suggest that the combination of carfilzomib plus dexamethasone should be a backbone for LEN refractory patients. So that abstract caught my attention. And the other abstract that I found very interesting is the one that Ludwin and colleagues are going to present about the effectiveness and safetiness of ixazomib based therapies in relapse refractory multiple myeloma, but treated outside clinical trials. And they conclude in over more than 300 patients, I believe, that they found a similar PFS and overall response rates that was published in the randomized control trial, the Tourmaline-1. So it's much more alike as our experience, which is modest in the Argentinian multiple myeloma group. That ixazomib is an effective drug and without any toxicities, in contrast to carfilzomib that we can never reproduce our results as shown in randomized controlled trials, such as Aspire or Endeavor. It's much more toxic. Latin America is a very heterogeneous region with different healthcare systems and different realities between countries. And we need local data to understand our epidemiology and how our patients are treated. So it's very important to join us together and make registries and so on.